And welcome to the Texas Epidemic Public Health Institutes and the P2R Consortium's Infection Prevention Lecture Series. Today's topic is going to be survey readiness. All of these lectures have been approved for continuing education. We'll get into that in a moment. Within a week, participants should receive an email with today's recorded lecture along with the slide deck. If you're new here, our structure of our lecture is usually first we go into the lecture, cover material, and then we open it up to a learning activity and we ask for everyone to participate, and then we'll open it up for questions. So I ask everyone to keep their questions until the end, where you'll be able to answer them. This lecture will briefly provide an overview of survey readiness, specifically focusing on the infection prevention and control survey plan and your annual risk assessment as well. My name is Dr. Kayla Rush. I have a PhD in epidemiology with a research focus on infection prevention and control education training, along with my master's in public health and environmental and occupational health. And I've been a seasoned IP certified in infection control for the last 7 years and in public health. And I will be today's speaker. So I work at the Texas Epidemic Public Health Institute, or TEPI, which is housed at UT Health Houston School of Public Health in Houston, Texas. And the goal of TEPI is to really create and improve the capacity and resiliency of Texas communities to help respond better to future infectious disease outbreaks. As I mentioned, this lecture has been approved for continuing education. And to obtain continuing education activity credits, you will need to attend 100% of the lecture, complete the post-survey test, receive an 80% or higher on that, and the post-lecture evaluation. And there will be steps after the lecture that will tell you how to complete these to obtain your email certificate for continuing education. This lecture has been approved for continuing education for medical continuing education, your CMEs, nursing continuing professional development, or CNEs, along with if your CHES, CPH, RS, and along with anyone that holds a certification in infection control or CIC from the Board of Infection Control and Prevention and Epidemiology. I have one disclosure. I am a consultant and speaker for BD, but no financial relationships or promotion of specific products that went into this presentation. So today's learning objectives, as I mentioned, we are going to describe and discuss kind of the survey process overview for healthcare settings. We're going to talk about 2 major surveys, and then we're going to go into within that surveys, how they look at the infection prevention survey and what their survey plan is. So what they are looking at, and they being the surveyors, either Joint Commission or CMS, when they come into your facility and want to know about your infection prevention and control department, program, education, and that goes into your annual IPC plan and risk assessment. So we'll be discussing all that. There are, due to time constraint, there are supplemental slides that I will not be going over under today's lecture, but when you get a link to the lecture and the slide deck, there will be additional slides that you can review. If you have questions, please email me. I'm happy to discuss them in detail at a later time. So let's get into today's topic. So the first survey that we're going to talk about is the big one, which is our CMS, or Center for Medicaid and Medicare survey. So what is this? A lot of us have heard of this. If you've been in healthcare, you know that this is a very, very important accreditation and survey that goes. So CMS is a federal agency. Which state agencies can come in and survey your healthcare facility as acting as CMS, or they have their own survey participants as well. And they look to see under conditions of participation, your COPs, to receive reimbursement. So under this survey, they were looking at a lot of regulatory compliance issues to make sure that all conditions of participation are met so that you and your facility can bill for reimbursement for Medicaid and Medicare. These surveys can be routine or for cause basis, and that can be for cause can be a complaint, an incident, or an outbreak. They're usually pretty standard when they come in, but if it is a for cause or for complaint survey, they will be looking at very specific things basis on what the complaint is, what the situation is as well. So when they come in, they are going to look at your infection prevention and control program, plan, your annual plan, your policies, the overall culture of IPC within your facility. They're also going to look at many quality assurance and performance measures, or your QAPIs, some organizations called KPIs, your key performance indicators. I talk about QAPIs and KPIs in previous lectures earlier this year, lecture 209 and 210 from last year, and from this year's lecture 301 and 302. They're also going to look at your nursing services and staffing, medical records, documentation, your environmental care, and your patient's rights, which goes into all of our HIPAA complaints and our HIPAA rights obligations that they're posted, that they're in the chart. If your facility is doing any type of research, all consents have been done, appropriate documentation has been approved, along with timeliness of documentation, a patient rides, closing out notes, closing out charts, all of that done. Because depending on what type of admission and what procedures that there are specific timeline regulations that things need to be done within the first X amount of hours, the first 2 hours, the first 12, the first 24, and then post-discharge as well too. If they are doing assessments and they find any deficiencies, three main things can happen. It's a plan of corrections or COPs, which really say that, they will provide a report and say that this was an area that was in non-compliance or a potential safety issue, and they are wanting you to change X, Y, and Z, or they are wanting you to develop a plan of action. What does that look like? Is that policy? Is that education, training? What does that specifically do? And they'll want you to implement it and track it and do a follow-up with the set time. There also could be fines and civil monetary penalties. So you can be fined a certain amount of money that the organization then has to pay for being out of compliance. And the most severe one is termination of Medicaid and Medicare funding. So if your facility receives that, that means I can no longer bill for Medicaid and Medicare practices and admissions, which is a huge billion, almost $1 trillion asset for healthcare systems. So it's a huge negative outcome if you have deficiencies within these things that then results to not being able to accept that type of insurance and bill for reimbursement. The next survey that we're going to talk about is the Joint Commission survey, which is more an independent nonprofit accreditation survey. So CMS surveys are regulatory, and Joint Commission is more accreditation. Sometimes, depending on the schedule and what CMS is going on, they will approve a Joint Commission survey to meet the requirements at CMS and demonstrate that everything is within compliance, but not always. It also depends on what type of survey that they're needing to do. If they're doing a complaint or for cause surveys, sometimes, most of the time, Joint Commission, CMS won't accept the Joint Commission because they are coming there for a specific action, compared to if this was just a regulatory survey that they're doing. Sometimes with the scheduling and how many hospitals that they need to look at, they will sometimes say it's deemed and met those needs. Joint Commission is usually 3 years unannounced. They use tracer methodology, so they will pull charts and they will watch a patient from start to finish, admission to discharge. They'll also pull charts, look at reviews, documentation. They will have interviews with staff, with departments. They'll do environmental care or EOC rounds and do a lot of direct observations and interviews is their main focus. And they look at slightly different things than what CMS does. That's also why sometimes you can do well in a Joint Commission survey, but then have harsh marking in a CMS survey, or have hard markings in a CMS survey and have lower markings in a Joint Commission. Since there's a lot of overlap, but it's not identical what they are looking like, there is sometimes problems with a certain alignment. You do well in one, you think that you'll do well in the other one, and that's not really the case. It also depends on your survey team, what's going on and what they're looking at your facility, and also how you've performed on previous surveys as well. So Joint Commission really looks at national patient safety goals, looks at infection prevention and control, specifically what CDC is saying. They do environmental care, emergency management, leadership communication, and performance improvement data use. So a lot of KPIs are wanting to know how we can improve. And the unique tool that they use is a safer matrix, which categorizes incidents based on risk, and I'll show some slides later of what that looks like specifically about their risk category. But they want to look at how severe the risk is, how often, if it's what type of patient concern it is. They look at EC, which is environmental care, IC, which is infection control, and LS, which is life safety standards. Some outcomes that can occur, you can have contingent or conditional accreditation, you can be accredited, or denial of accreditation, which is really rare. That usually does not happen. So here's just some key differences between the two types. As I mentioned, CMS is regulatory, Joint Commission is accreditation. Frequency slightly varies. If there's a for-cause survey, they will be there. It doesn't matter if you were just surveyed by CMS last year. If there's a complaint or for cause or an incident that happened that needed to be reported, they will be there. It's, as I mentioned, CMS is very regulatory focused, and Joint Commission is really looking at quality improvement. They both are unannounced. However, sometimes with Joint Commission, when you're talking with your quality department, they kind of know when you're, quote, in the window, which means that your survey date is coming up, so that likely you can prepare and look at when Joint Commission will be there and start reviewing policies, education, rounding, looking at staff, talking with staff that they all know the practices and can speak to the practices, or if they cannot, they know what to say exactly of, let me go to the database and pull the policy and procedure, let me find my manager, those very survey-based questions and responses that we should all know how to say. They do a documentation review, and they do a lot of interviews and observations. So those are kind of the two big surveys that infection prevention and control plays into. And then specifically now we're going to start talking about what they kind of look like within the scope of infection prevention and control. So when they come in and audit infection prevention and control, it is a very structured way that they are looking, and they're evaluating your type of department, culture at your organization. And most of the time they are looking at hand hygiene, PPE, environmental care, life safety, as I mentioned. Also just looking at regulatory standards, identifying risks, and then recommending improvement. So they're trying to make sure that we are staying safe as healthcare providers within our organization, and we're also providing the best care or reducing harm to our patients. So most of the time, their objectives and scopes is to specifically look at the adherence and evaluation of practices, and their main focus is identifying gaps or addressing ways that we can improve compliance with regulatory requirements. So making sure that we're all within our standards, we have great focus, where it is a safe place for our patients and for our healthcare workers. Most of the time, they will look at infection prevention control policies, procedures, and within departments, specifically the infection prevention control plan, which is going to be the last component of this lecture that we're going to talk about. They'll also look at hand hygiene, PPE, isolation, environmental care, and surveillance of HAIs are a very typical focus that most of the time when they are in here, they are wanting to look at and review these types of events and these specific elements within infection prevention and control. The methodology that they usually use is one observation. So they will do direct observation of staff. So they will, as soon as they come into your facility, they will be watching all staff and all departments. It's not just nurses, it's not just physicians, it's not just environmental of care workers, it's everybody. Everyone they are going to be watching, they're going to be observing. Then they're going to interview. They're going to interview the infection prevention and control staff, this specifically within the departments, but they're also going to be asking other departments about the infection prevention and control policies and procedures. So not only does your policy in your department need to be able to state everything within your policies, but the whole other organizational staff, everyone within your building should be able to recite some of the infection prevention and control policies and procedures, or at least know the basics of what products to use, how long they need to have their wet time, what products are used on what equipment, what isolation is, what good documentation, who is their infection preventionist, what's their number, all those types of things. They will be directly asking the staff. So definitely making sure that not only you know all the information, but all your staff at your organization knows the information. They'll also be reviewing documents, not only the infection prevention documents, but other documents pertaining to infection control, such as physician, nursing, ancillary staff regarding infection control. So if a patient is on isolation, they will be looking at the isolation signage. They'll be asking the staff, what type of isolation signage is this? When do you put this? When do you take it off? What does this mean? How is this information disseminated? And then they'll also be looking at, is that documented on the chart? And has the patient been educated on their infection status and the education provided to the family? All of that documentation will be reviewed. And then lastly, they'll do a walkthrough. So they'll conduct physical rounds. So usually they will start off by conducting, as soon as they walk in the building, they will have a command center your organization will set up. You'll have people, scribes, go with them to talk, answer, show them around. And the whole time they're walking through, they're observing, they're interviewing, they're looking at documents while on their round. So all four of these things are happening simultaneously during this process. And the survey process, depending on what type of survey, what type of facility, and how big and what communities that you serve, your survey could last a couple days or it could last a couple weeks. It just depends on what's going on, what type of survey is it, what are they finding, is there issues? Usually if they are not finding non-compliance, they're in and out, usually within 3 to 5 days. If there's finding non-compliances, that usually is then lead them to look at other things and they will be there longer. So they will look at, as I just mentioned, compliance, not only within the state and local and federal regulations, but also look for compliance with best practices and regulations and recommendations from OSHA, NIOSH, CDC, WHO, Joint Commission. They'll do risk assessments, so they'll constantly evaluate what's going on, what's the risk, what type of environmental conditions put healthcare workers and patients at risk. Look at your infection control practices and procedures. They'll also review your training and education. So they'll go to HR and pull your files on what type of accreditation that you have for your credentialing. They'll pull your credentialing, or they'll go to credentialing and pull your credentialing files. They'll look at your annual compliance training. They'll look at your annual OSHA bloodborne pathogens training. Any type of certifications that you have that they're being maintained, that your CEs have been submitted, they'll be all looking at that. And then within the organization, if there is special education for a certain medical device or procedure, they'll be reviewing that as well. Then based on all of that, they will start developing surveys and questionnaires. They'll look at, what to ask. They have checklists, and they have procedure areas of what they go through and kind of what they look at. Joint Commission has very nice checklists that you can look at, that you can download, for some free, some for a cost. That really kind of goes through about the regulations, the number, and what that specifically means. Some of the 200 and the 100 lecture series on the infection prevention and control, I go into detail about Joint Commission rounding and going through their environmental care. Refer back to that. That's a good practice of looking at those specific documents. Also in those lectures, there's in the resource and references section, there are links to them so that you'll be able to see what that printout looks like and be able to use it as well. They'll also lastly, they'll look at your infection prevention data. So they'll look at your HAI, your antimicrobial, they'll probably look at your angiobiogram, any outbreaks, what type of outbreaks, has it been documented, has it been communicated to local or state authorities as needed as well. So based on all that information, then they will start analyzing, start reporting. They'll create different types of reports, identifying trends, areas of weaknesses, things that are going right, and areas of improvement. They'll also provide follow-up of what you need to do. Is this within immediate action, or an IJ, which is immediate jeopardy, which that they can pull your licensure if things are not handled appropriately and timely, aka right now. You need to fix this, because they call it immediate jeopardies, that if this was a big systematic failure, this could result in the loss of human life, either a patient or a staff member. And those are pretty severe citations that you need to address them very quickly. And it's kind of at the organization level, when that happens, it's an all hands on deck type of situation. Everyone is involved trying to rectify this and either retrain, re-educate, re-implement everything. So it's working as an organization to improve these defects, and that this doesn't happen too. They'll provide you with a report, and then they'll also give you an action plan and a time sequence of when things need to be done, how they need to be done, what specific things they want you to be done. After that, then they'll give you a timeline of when you need to submit certain things. Sometimes they will come back and physically revisit you and want to see that this has been implemented. Sometimes it's submitting documents and they clear it. And sometimes it's a couple different follow-up visits. So it's depending on, as I said earlier, depending on what type of survey it is, how they're scoring it, what level of severity of scoring that they're giving, that the follow-up might be just submitting a document or two, it might be doing virtual meetings with them, or it might having them come back and revisit and resurvey you. And the importance is that they're really just there to make sure that we're all within compliance and that we're keeping a safe environment for our healthcare workers and our staff members. And main focus areas that they look at is hand hygiene, always hand hygiene. As soon as they walk in, they will be looking at where your hand hygiene dispensers are, how full they are, how many people are accessing them. If anyone is on C. diff protocol, that they shouldn't be using alcohol-based products, they're washing with soap and water. They'll be looking at PPE, your usage on PPE. If there's PPE in the hallway, people know how to use their PPE. The people are fit tested. They know what size their N95 is, and they can say that, or they have tappers and they have been trained and they feel comfortable. Isolation precautions. As I mentioned before about documentation, that staff and patient know about these things. Infection prevention surveillance, so looking at your trends, training records, environment of cleaning. So if you didn't attend the earlier lecture this year on environment of care, healthcare environmental care, please go back and review that. It talks a lot about the cleaning protocols within the environment and life safety components within that area. And then lastly, documentation reporting. Just like in healthcare, everything needs to be documented. If you don't document it, it really hasn't occurred. And especially for regulatory and compliance, if there is a problem and has been identified, they need specific timeline of what did you do when to try to rectify, improve the situation, and then that you monitored and trended out. So the next section we're going to go into is the infection prevention and control risk assessment and plan. So this is a specific document that during the survey that they are going to ask you for, and it's built on many, many different things, your specific plan. So first, before we can talk about this big document and how you should develop it based on your department, we need to first talk about the basics of what a risk assessment is. So a risk assessment is a systematic processing of identifying, analyzing, controlling hazards and risks. So in infection prevention and control, if you're new to the field, a lot of times we talk about risk. We talk about attributive risk in the epi world. We have our risk ratios, our RRs in the epi and statistical world. And then also when we talk about potential events and outcomes, you should always say that a certain level of risk is X, Y, and Z. We can never say with certain that this is going to happen. Because a lot of times we do a lot of forecasting training. We are aware of what's going on locally, within our community, within our state, and then nationally and internationally. So we're trying to prepare, and with all that information of what's going on with pathogens, supplies, patient moving around, and just kind of what's going on, we can develop of what type of risks we can plan for and do risk assessments to try to minimize the risk along the way. Why is this needed? There's always some level of hazard. In the hospital, we work with a lot of big of equipment. There's potential risk and hazard to that, working, say, with any types of needles or sharps or scalpels. There's a risk to our patient, but there's also a risk to ourselves that we can have a needle stick, we can have a sharps injury. We also, if you're going into x-ray, and not wearing aprons, you're having some level of exposure to yourself, from material. There's always a risk in this facility and in this setting just by the nature of the work. So we will always want to make sure that we are aware of these so that we can eliminate or control the level of risk, aka make it safer for our patients and for our healthcare providers. When do we conduct a risk assessment? Anytime you have a you conduct a risk assessment, anytime new process, so any type of new policy procedure, you always want to do a risk assessment. If you're changing any type of the workflow, making sure that it's safe, that it's operational, it doesn't affect throughput. Ergonomically, staff are not going to hurt themselves doing this. If you change the flow of the room, how you're handling patients, you always want to make sure you're doing a risk assessment, doing a walkthrough to make sure that it's safe, it's providing improvement for everyone. Anytime when you make any changes to processes and workflows, anytime there is a new piece of equipment or new tool, you always want to make sure that you're doing a risk assessment. You're talking about all the what ifs with this new product. What if it fails? What happens if we can't get it to work? Do we have a backup? How critical is this? You want to be asking those what if questions with the new equipment. And then when a hazard or problem occurs, that we're doing a risk assessment. So what is going on? What could happen? And then, if it's hurricane season, if there's a hurricane and we go out on electricity, is there a risk of that happening? Yes, we're in hurricane system. So what are we going to do to mitigate those risks? This is important to really conduct these risk assessments to identify hazards so that we can put the proper controls and we can kind of plan so that we have reduced harm, and we stay safe within our hospitals, our healthcare systems, for our employees and for our patients. So with the risk assessment, just like quick little 6 steps, which seems very complicated, but once you get in the motion of doing risk assessments, these come very quickly. And in infection prevention and control, we do risk assessments on the fly. These can be very formal things that you're writing up, doing a policy, procedure, protocol for a risk assessment, or this is just a situation such as, a patient's family member came into the hospital, they weren't wearing a mask, now they're coughing. Is this a good thing or bad thing? When you're proposed a situation, you're going through the steps of what could happen, what's the severe case, what's the low case, what should we do next? And then you're talking with a lot of areas, because when it comes to infection prevention and control, it's not just one area, it touches everybody. So you want to make sure that you're talking with administration, with different departments that are affected by this, that it all is operationally can be done and you can implement it. Because sometimes our risk assessment, what we want to do is not operational. We can't actually put that in place. We either don't have the staff, the time, or the equipment, or just it's not realistic. That's another thing. So making sure that you're talking through these events, but you want to identify the hazards, who might be harmed and how, elevate the risk and decide what the precautions, aka how can I decrease the risk, implement those controls, record your findings and communicate them. And that is something specifically for step 5 during regulatory. They will specifically look at your communications and findings and making sure that has been disseminated to everyone. They will look for that very in detail. So make sure that, yes, if you verbally present this to the situation, then you either go back to your office, you write it down, send an email, some sort of traceable documentation that this happened or this was the situation, this is what was done, and then review your assessment and update it as needed. So as a situation evolves, you're constantly reassessing and updating and modifying as needed when more information is becoming available, when staffing's changing, when equipment or resources levels change, or just the influx of patients change as well. And some of the ways to control and conduct risk assessments, your hierarchy of controls. So the big one is always elimination, substitution, engineering, administration, and PPE. There's a great graphic by NIOSH that really looks at just the basics of, if you eliminate, you physically remove the issue, great, not a problem. Substitute it, you replace it. Engineering controls, so our engineering controls would be putting infectious patients in isolation rooms or negative pressure isolation rooms, so that we are placing them in a room that has an engineering control, such as our HVAC system that has changeover of our air within a room for a certain pathogen for a certain time. That's an engineering control, so that we don't have exposure out into the hallway or into other corridors. Our administration controls, that's our policies and procedures. And then PPE is the physical thing. And as you see, the most effective is elimination, and then the least effective is PPE for those levels. Okay. As I was talking about earlier, the different risk matrix, when Joint Commission and CMS are in there, they're specifically going to look and evaluate the different risks. This is one of those matrices. So they look at the likelihood and consequences. And this will also go into how they're citing you. So something that is almost certain to happen and catastrophic, that's going to be immediate jeopardy citation that you need to fix immediately, or they could pull all your accreditation or credentialing and regulatory component too. Compared to something that's insignificant and low, they might just identify it. They might not ask for an actionable thing from you, but just to be aware of that. So this is kind of a way that they look at it, is rare, likely, possible, unlikely, and most certain, and then insignificant to catastrophic. And you can see the matrix, low being green, we always want to be in the low, yellow is medium, not so great, and high we need to address, and then extremely high, address immediately. We also do, when we're talking about risk and risk assessment, we also do situational risk assessment, just like I said earlier about the patient's family member that comes in that's coughing or has a fever. We always want to look at the who's at risk, the what's going on, what's the process, or is this something individual or within affects the whole organization? Where is this occurring? Because that will also play into your risk factor. A situation in a non-clinical space, such as you have an administration worker come in with signs of flu-like symptoms within the office that comes in to work. They're there for maybe an hour or two, and then they decide to go home. They're febrile, they're coughing, sneezing. That exposure in that area has a different risk than a nurse in our medical intensive care unit or ICU that comes in with the same signs and symptoms in a different area. So where is very important, and then when. Also, when is this happening? Is it happening during a procedure, or is this happening downtime on someone's break for a staff member? Is this also happening, going back to where is this inside or outside? That's another big thing. And then also, if you're trying to understand what's going on, looking at what time of day during operation cycle is also important. So knowing about what is going on at the organizational level when this is going is really helpful when you are trying to develop and implement and operationalize a risk plan. Doing stuff at different times of the day, sometimes it's operational, and depending on the day, it's not operational. So knowing that in advance and kind of just be mindful when you are doing your risk assessment is always really important. And then lastly, asking people follow-up questions. Most of the time when we are presented with information, we are not presented with all the information right away. As an infection preventionist, it's one statement. This patient X came in with a rash. Okay, that could mean a million different things. There's lots of different types of rashes. There's autoimmune rashes, there's chronic rashes. They could be more, and there's infectious rashes. And is this a true rash? What type of rash? Is it pustules? Is it draining? Where is the rash? All of these are important questions. So definitely make sure that if you don't have a clear picture when you are doing your risk assessment, you're asking questions, you're asking follow-up questions. And don't let them intimidate you by if they're, short with you by the information that you were provided. Reaffirm with them that, you're here to help. You are the expert. You are saying, you called me for guidance, what policy or procedure, how to act because of the situation. I need more information to tell you the best thing to do. And sometimes it's just going up to the unit or going to that department and seeing the patient, talking with the staff. Sometimes you can talk things on the phone or look at patient's chart, but actually going visually and seeing and getting a sense of what's going on is also really important. Also, with just getting a touch of what the climate is of the situation, what is the fear of the patient, the family member, and the staff going on as well. So that can play into what type of risk, how you can decrease the risk, kind of de-escalate the situation as well, as you'll sometimes need to get involved in that level and be mindful. So now we've done a lot of background information on risk. All of that goes into our annual infection prevention and control risk assessment, which is the base of our infection prevention and control plan. So you do an annual risk assessment that goes into your annual plan, which you develop your department goals and objectives through that plan. And that plan is specifically what Joint Commission and CMS want to know and will ask for, especially when they come and interview the infection prevention and control department about certain things. They will ask for your plan. Depending on what type of facility you are, if you are a 50 bed or 500 beds, if you're a level 1 trauma or level 4 trauma, NICU, burn, oncology, neuro, all of those things will go into what type of plan you have and what are the risks within your plan based on the service lines and also what type of patients are within your community. Do you have patients that are lower socioeconomic that usually do not seek healthcare? They might have a lot more chronic issues that are unmanaged, or does your patient community come from more affluent patients? They have healthcare, they're going to the doctor regularly, they're overall pretty healthy, they have good med management, they have a PCP and they're being followed up and everything's kind of more within control. Those things will all go into how you score that. So this is kind of an example of what your infection prevention and control risk assessment looks at, and it will look at potential problems, your scoring of them, and then probability of performance impact the infection prevention system, and then your scoring and your goal. So we'll give you a number and your goal. You will set your goal at your institution. If you're not sure what a good goal is, look at the last year's plan. This plan is done every year. So if you're new into your department, new into this role, or new into this facility, ask for last year's plan and look at it. Look to see what last year and maybe the year before that, what were the issues and how did they score things? Then you're going to score it from 0 to 3. 0 meaning not a problem, things are going well, and 3, there is a problem, we need to be doing re-education, training, modification, it needs to be addressed. So the lower the number, the better. That's the good. And within your plan, you're going to score it from multiple components. You'll have your HAIs, you'll have prevention failure activities, employee health, policies, procedure, preparedness, environment, antibiotics resistant, and you can have additional things. Look at your plan at your facility, see what they looked and developed before, and then decide if that's needed to drop onto your plan or if you need to add things. Maybe since this is Texas and there's been outbreaks of measles, maybe increasing for specific pathogens on your plans, maybe measles needs to be there. Maybe TB needs to be there. Maybe COVID was there because you were in a very dense COVID facility, and maybe it's decreased more, and maybe that doesn't necessarily need to be on there. Look at those types of things. You can add and subtract them. But make sure you're able to justify that, because when surveyors look, they might ask for this year's plan and last year's plan, and they might ask you, why was the previous year, did you have this on your plan and you don't have it on this year's plan? And then you will score it like this. So this is kind of just a snapshot of the last couple slides of how then it will look in setting your scoring and setting your goal. Okay. So then based on your scoring and your risk assessment, you will now develop your plan. So you want to analyze the types of scoring that you just did. So you want to look at your different categories, your HAI trends, what's going well, what's not going well. Are all your HAIs in trouble and trending up, or just a one specific? And then what type of patients do you have? Do you have a lot of high-risk patients, immune-compromised neonates, bed patients? Or is it more low risk? What type of procedures and units do you have? As I mentioned earlier in the lecture, different units and different departments will have different risks. Being in surgery and ICU has a different risk than just being on the medical floor or being in an outpatient clinic within your facility too. Device utilization and antibiotics use, always a thing, making sure that you know how many devices you're using, central lines, Foley catheters, and then your antibiotic usage. If you're not sure what your antibiotic usage is, ask your pharmacy folks. They are happy to talk about their antibiogram. They love it. They will produce it. You should be going to your stewardship or your antibiotic stewardship meetings and your committee meetings, and you'll have a lot of that information and pull it into your infection prevention control, environmental concerns, and then compliance with your data of those things. So then based on that big scoring system, you're going to have a lot of metrics. The best way is to systematically attack them. Do not try to fix everything all at once. That doesn't go, and people's bandwidth capacity is usually not beneficial. They can usually just handle a change to a couple different things. Also, be aware of when you are trying to implement new things, take a minute to see what the culture and climate is within your organization. Are you guys ready, staffing, equipment, and mental capacity wise, to start something new? Or your staffing shortage, resource shortage that maybe not now, but in a month or two when we get more staffing. Especially now, if you're in the academic center, you have the new residents coming in. Maybe giving it a month or two before starting a project with them, especially with issues relating to your physicians, giving them a little bit of time to get acclimated to their new roles. And then looking at your top 5, your 3 to 5 top areas, you always want to start with the most severe and handle those right away, because that will lead to the bigger fine or citation from Joint Commission. So the more severe things, ones you want to handle right away. Based on that, then you are going to develop your step 3, your SMART goals, which is your specific, measurable, achievable, relevant, and time-bound or timely goals. If you want more information on developing SMART goals and KPIs, lectures that I did last year, specifically 209 and 210 really talks about that. Please go back and look at those. They will walk you through that. Then you want to identify what interventions and responsible parties. So what are you going to do and who is responsible for it? And then making sure that you can do this operationally and timely within. So you making sure that you get everyone on board, you're discussing what's going on. Remember, infection prevention and control is always collaborative. It's not just the infection prevention control department, it's every department that we touch. So when you are doing these new initiatives on certain goals, you need buy-in from them. So make sure that you're having those conversations and inviting everyone to the table from the beginning. You'll have way more buy-in than if you try to start out small and then add people later into the process. Then step 5, you'll create a timeline. So either quarterly or monthly benchmarks for implementation. So how you want to roll this out, what percentage, if there are certain metrics you want to be hitting, that's all discussed and within your timeline. And trying to have your timeline as fixed, but also allow for some fluidity. Sometimes we have an outbreak, we have a new pathogens, we have staff shortage, we have resource shortages due to hurricanes. We a couple years back, it knocked out all of our saline. So then, that was a problem. So make sure that there is some fluidity and that you're updating it as you go. You're integrating surveillance and monitoring. So you're constantly not just deciding these metrics and leaving it, but that you are actively reviewing them, you're meeting, you're checking in with the team, what's going on, you're doing audits, you're looking at your outcomes, and you're processing these metrics. Then all that information is communicated and disseminated. So you are telling people what's going on. That includes your executive leadership, department manager, your safety and quality committee, and your frontline staff. They want to know what's going on. Make sure you tell them or have the department manager disseminate that information. This takes a team. Everyone has to be on board for infection prevention and control. So making sure that everything is talked about. And also during the surveys, they're going to ask you, they're not going to ask you infection prevention, but they're going to ask the staff, well, what does the infection prevention team do? What are some projects they are working on? What's some initiatives? You want to make sure that you are always disseminating this information, that your staff can speak to it, and that people in the organization know that this is a priority and you're building that culture of safety and infection prevention within your organization. Step 8, evaluate and update, always review, semi-review, and then modify. And then based on what's going on with this and how you're trending, you can decide to do this and add it into your plan or not. Evaluating and looking at this either quarterly or semi-annual can give you justification of adding things into your plan for next year or removing it, especially when the surveyors are there and they're asking you if you this was done in the previous year and now we're on this year, why did you remove it? If you can show last year this was a problem, we did this, we have documentation, these were our metrics, this is what we did, this is how long we monitored, so we removed it from our plan. Or scored it significantly less because then, we show a reduction in harm in this event, they will not have any follow-up questions for you. So documentation, follow through, making sure everything is done in a timely way can at that time can really help you prepare for survey time. And this is just an example of like a plan development that you can use. Every organization kind of has their own format. Sometimes it's in like a PDF Word document. Sometimes it's in charts, tables. It could be in spreadsheets. It just depends on what your organization does. But this is just an example of, how you could put one together of looking at your risk areas, your goals, metrics, and then your timeline. So specific, you can say. Okay. So I know that was a lot of information. So now we're going to go into a knowledge check, just some quick 10-question, multiple choice answers about some of the material that we went through today, and then I'll open it up for questions. And during this time with the knowledge check, if you're new here, I encourage you to put the correct answer in the chat or unmute yourself and you can speak the right answer. So I'll give it one more second, couple more seconds for you to scan the QR code, and then we'll start with the questions. Great. Okay. Okay, question 1. What is the main purpose of the CMS survey? Is it A, B, C, D? Yes, that's great. It's B, to evaluate conditions of participation. Question 2, which of the following best describes the Joint Commission process? So now we're talking about Joint Commission. Is it A, B, C, or D? Great, yes, B, they're unannounced. Okay, question 3. What is a serious outcome of the CMS survey? A, denial of accreditation. B, accreditation with follow-up. C, termination of Medicare and Medicaid. D, plan of correction. Yes, this is C, termination of Medicare and Medicaid. That is a really serious outcome of the CMS survey. Question 4. Which of the following does the Joint Commission assess during the survey? Do they look at infection prevention and control programs, environmental care, emergency management, or D, all of the above? Awesome. Yes, the correct answer is D. They look at all of those things plus many more. Question 5. What method is used during the Joint Commission survey to evaluate compliance? Do they do tracer? Do they do documentation, patient interview, or self-assessments? Yes. B, tracer methodology. They will pull a person's chart and they will walk through that chart. They'll walk through that patient. They'll go everywhere with them, go to the different departments. Also during this time, they will ask, sometimes they ask staff to observe, but it's kind of a voluntold they will be observing, but depending on the how critical the patient is and what's specifically going on, sometimes there is a little bit of leeway, but most of the time they will ask to observe, and the answer to that question is yes, you can observe, unless it's a emergent case. Usually then they will not pick those charts to observe. So sometimes they'll ask and they'll review the chart a little bit more of say what's going on. They'll get some background information if it's safe for them and other staff, or if they think that this could be a very complicated case and there's gonna be a lot of people in that too. So they do take that into consideration as well. Question 6. What are the components of the infection prevention survey plan? Is it A, objective scope and survey method? B, interview, hand hygiene? C, they only look at environmental cleaning? Or D, none of the above? Great, yes. The answer is A. Great job, everyone. Just a couple more questions and then we'll open it up for questions. Question 7, when should a healthcare facility conduct a risk assessment? When a new piece of equipment is introduced? When a hazard has been identified, when changes are made to the workflow, or D, all the above? Yes, D, all the above. It is really important, even if it is just a small change. Make sure that you are at least going through and having the conversation, not only you as the infection prevention practitioner, with the department head, with the staff, to make sure that all the bases are covered. We want to make sure that when we are changing and modifying things that everyone has been educated, they approve, it is actually able to be implemented. Because some things sound great on paper, but then when you actually get into the space with staff and the patient and the equipment, you can't actually implement them the way that they want that is being proposed. And so definitely make sure that you're doing a walkthrough, you're talking about it anytime that you have a new piece of equipment, changes to workflow, or a hazard has been identified. Question 8, which of the following is assessed during the IPC regarding staff training? Do they look at their training records and competencies, medication training, leadership effectiveness, or only hand hygiene? Yes, they will look at A, the training records and competencies, because they want to make sure that they are looking at within your scope of practice, then what is deemed of the infection prevention and control training that you should have. For example, in sterile processing, when you are looking at any type of equipment that needs high level disinfection or sterilization, there are specific education that falls under that those staff need to have. So they'll look at that within their scope of practice of what they're doing, compared to they wouldn't pull that type of training or ask for that specific training on something for a nurse at the bedside that's in med surge. That's not in that department. So it's very within the scope of practice. They're then pulling your IPC training and they want to know what you're doing and then what IPC training that you have. Right. Question 9, what is a SMART goal? Is it A, 100% reduction, B, 30 to 50, C, no change, or D, 50? Yes, B. It has a realistic, and it also has a measure of time. There should also be a measure of time. I'm saying we want to do this in quarter one, quarter two, month one or two, X weeks, X days, some level of a time element too. Okay. And then question 10, what is the purpose of conducting a facility walkthrough? Is it to evaluate performance? Is it to ensure facility meets cleaning and infection control practices? Is it to assess patient satisfaction? Or is it D? Yes, the right answer is B. Say patient satisfaction goes into your HCAHPS scores, which is a totally different metric that we weren't discussing today, but patient satisfaction does go into a regulatory component and goes into other metrics within your organization as well, but that's a whole other thing. But yes. So great. So if you missed any of the answers, here is the correct answers. So to wrap up this, being survey ready takes a lot of time and effort, and it's very, very important. This shouldn't be done just within the idea of you're up for your triennial survey in the Joint Commission instance. That comes every 3 years within your survey window. And then knowing that, hey, your time's up for re-accreditation. You should always be survey ready, because that really shows that you're dedicated to safe standards and best practices for our healthcare workers and for our patients. So it takes a lot of time to be survey ready, as people say. I'm making sure everyone has been trained, been documented, educated, they feel comfortable, they know what to do, who to ask, and who to ask if they don't know. That's another big thing with the survey. Not every person will know every answer, and even a very seasoned survey person might ask a very difficult question to someone, and it's okay to say, I'm not sure, let me reference the policy, or let me grab the policy for you and we can look at it together, or let me go ask my manager, let me go ask my leader. Instead of, you don't ever want to make anything up. So making sure that staff know that, but also, you know, they can speak to their practices, they know their practices. And it's really beneficial for everyone, because if they know it, they can speak to it, they're doing it, that really creates a safer environment for all of our patients and our staff members. So I welcome everyone to connect with us. Here is our email address. Here is the QR code to some of the other TEPI components within our organization that we do. And our next lecture that we will be giving on July 3rd, yes, July 3rd, right before the 4th of July, high-level disinfection. And we'll talk about, briefly talking about what high-level disinfection is, talk about the process, and talk about how to monitor it. And then I ask everyone to please take the post-survey evaluation survey, which really rates the course, the material, lets us know how we're doing, what type of material you want for future lectures. A lot of this information and the feedback that you provide us, we use to build future lectures and future series. So that's very important. Also, for our upcoming modules, if you haven't done so, you can register for the other lectures that we're holding here, and that is this QR code. And then also, as I mentioned before, within a week or so, you'll get an email to today's recording along with a slide deck. And I am also asking everyone if you can complete this additional survey. It's a midpoint survey of the infection prevention and control series. And we're specifically wanting to know what's going on. There's been so many changes going on at the local level, at the state level, at the federal level. You know, what are the current IPC barriers that you have? And if you by letting us know, we can try to develop and create more resources to help you address those problems. Just like if you complete the other post-survey evaluation and this one, your name will be entered into a drawing to win some TEPI merchandise. And then here are the instructions to complete the continue education credits. So you'll register, there'll be a couple emails, and then they'll ask you to complete the post, the learning activity and the per survey evaluation, then I'll send you an email with the approved hours of continuing education. And I want to thank you all, and I'm going to open it up for questions. I know today was a lot of information. It was very regulatory heavy, but it's very much needed. So please ask away any questions that you might have. Yes, I can go back to the QR codes. And here's this one too. And you will get the links in a week, as I mentioned, with the slide deck. You'll be able to see these within the slide deck too to complete. So if you don't get a chance to complete them today, within a week or so, when you get the link with the slide deck to today's recording, you should be able to complete them now. And if you don't receive it, please email and we can send them to you. Any questions? Okay. Well, if I'm not hearing any questions, it was a pleasure to speak to all of you, and thank you for coming to the TEFI and the P2R Conservio's Infection Prevention Lecture Series. I look forward to seeing all of you at the next lecture on July 3rd, talking about high-level disinfection. Thank you.